various uh, things. What is myasthenia gravis? So what happens in myasthenia gravis is there is a particularly facial and other weaknesses there. The person will have very weak muscle and therefore find difficulties. So what it is an acquired immune disorder. It is characterized by weakness of skeletal muscle, and since the muscles are weak means their tone has reduced. I have asked you to read what is muscle tone. So muscle tone is reduced. So if the muscle tone is reduced, then they have to work more for having same muscular contraction, and so it has to spend more energy. Therefore, it is a fatigability on the exertion. It was found in 19 1672 by Thomas Willis. This type of situation, and it is very famous in India because Amitabh Bachchan has got it when we were studying, and you can understand the way Amitabh Bachchan has dealt with it, because since we were studying almost 35 years ago, it was diagnosed with Amitabh Bachchan, and his job is of muscles only, that is skeletal muscle, particularly facial expression is on depending on the contraction and relaxation of facial muscle, and despite of that he is in that profession. So what is happening in the is a problem with the neuromuscular junction. We know what are the components of neuromuscular junction. That is, there is a presynaptic neuron, that is postsynaptic, and synaptic left is there. Acetylcholine is this, and that acetylcholine binds to the receptor on the postsynaptic membrane, and these are nicotinic of receptor, particularly skeletal. So we have seen all this how it happens. We have seen various neurotransmitters are there. We have seen how the things are there. That is neurotransmitters, particularly post synaptic density of their better calcium channels are there. Because of that, they cause exocytosis. This everything we have seen earlier. What is we have checked how acetylcholine comes in. So everything is earlier studied, and how release takes place. Then it binds to nicotinic receptor, and because of that, what happens? So nicotinic receptor, we know they are membrane-bound receptors, and these membrane-bound receptors are having the transporter linked activity. So it is bound to the sodium channel that will open when acetylcholine will bound. Because of that, sodium will come in, and there will be excited to the postsynaptic potential that we call it as a EPSP. Because of that EPSP, these sodium channels will open, special potential reach, and because of that calcium will come in. Then pathophysiology, that is the antibodies are directed towards the acetylcholine receptors in myasthenia gravis. So this we call it as an autoimmune mechanism that normally it should not happen, but in this person the antibodies are produced against own receptor. Otherwise, body is totally protected from own such defense mechanism. But here it is either overactivation, or because of some structural differences, changes, or because of certain chemicals which binds, it appears to be foreign, and these antibodies, they will attack on the acetylcholine receptors in the neuromuscular junction of skeletal muscles. Because of that, they will decrease the number of nicotinic acetylcholine receptors at the motor end plate. Motor end plate means we call them as skeletal muscles. Okay, that will cause reduced postsynaptic membrane force, and that will cause widening of the synaptic cleft. Because of that, lesser contraction will be there, and as I told you earlier, it will cause decrease in the muscle tone. So this is how the actions will be seen, or this is how that is the pathology of myasthenia gravis. So what are the basic thing that is in 80 to 90% of the patient with the myasthenia gravis, the antibody for cholinesterase receptor, acetylcholine receptor, particularly nicotinic receptor, antibodies are found, and these antibodies are acting, and they are there. So it can be considered as a beta cell That is, we know T cell and B cells, lymphocytes are present, which are playing role in immunity. So these B cell particularly are playing important role. T cell are responsible for cellular immunity, and B cells are responsible for humoral immunity. That is, they produce antibodies. So thus antibodies will be produced, and these antibodies will be binding to the nicotinic receptors. Nicotinic again, nicotinic and M type of receptor, nicotinic muscle type of receptor. Because of binding with these antibodies, two things can happen. One is they will block the binding of acetylcholine is one thing, and second thing is because of the antigen antibody complex, cells, the phagocytotic cells can be engulfing that receptor, and because of that receptor will be totally made unavailable, or they will be removed from that. So it has got some immunity influence. It causes thymic hyperplasia and thymomas, that is thymus are there. They are also recognized in the patients with the myasthenia. As I told you, T cell causes the cellular immunity, and because of B cell, T cell can also be activated, and they will cause the more engulfment of that. How much is there in US? It is 2% in around 10 lakh people we can see, or 2 per million we call it as a worldwide prevalence is 1 in 10,000. Mortality, morbidity, recently there is a decrease in the mortality because we are having so many treatments available. Earlier it was not so easy, and many people were dying up to 30 to 40%, but now it has been reduced to 3 to 4%. What are the risk factors? It is surface after the age of 40. When it goes more than 40, then it is there. And when there is a hyperplasia of T cells, that is thymoma, in that case it is there. What are the incidences again? Female to male ratio is 6 as to 4. That means if the 10% are 10% are recognized, then 6 can be female and 4 can be male. The mean age is in the male around 42 years, in female starts early, that is around 28 years, and that is peak, that is highest in the age of 60 to 7 decade, that is in the age of 60 to 17 male, while in female in 30 it can be found more. Now what happens in that, what clinically happens, or how one can diagnose it? So it is a fluctuation in the weakness, that is fluctuating weakness is increased by exertion. Weakness increases during the day and improves with the rest. There is extraocular muscle weakness, that is muscle nearby eyes, they will be weakening. Ptosis is present initially in 50% of patients, and during course of the disease, 90% of the patient will show this. The head extension and flexion weakness. Extension means up and down movement. That is called as a extension and flexion. Last year, I am very sure you might have studied it in uh, skeletal movement, uh, uh, flexion and extension, particularly of the pivot joints, which we have seen, that is in hand, leg. Okay, so extension and flexion movements are there. That will be weakness, and in proximal muscle it will be very more severe one. The progression of disease will be there, mild to more severe over the weeks, 2 months. Usually spread from ocular to facial, and then valvular to truncal and limb muscles. So initially it starts with the ocular, that is the diagnostic, then facious. The face will be, rigid face. That means expressions will be difficult because muscles are they become flaccid, no contraction or less contraction, and then other muscles slowly it will be increasing. The symptom may remain limited to the extraophthalmic muscles and eyelid muscles for years. It is good, but if it goes beyond that, then it can lead to mortality because other skeletal muscle, example, diaphragm is important muscle. So if diaphragm is affected, then it will affect respiration. So this is how it is affecting. The disease remain ocular in 16% of the patient. Immediate remissions are rare, means with treatment slowly it can be there, but then that is not that big. So how will diagnose it? We have got various testings. Example, muscle strength testing. Recognize patient who may develop respiratory failure because they are finding, as I told you, uh, the major problem with this is diaphragm is a skeletal muscle. We have seen that skeletal muscle contraction is affected. So if diaphragm contraction is there, is affected, then it will be difficult in breathing, and we call it as a respiratory failure. Then sensory examination and other examinations are done, and then the muscle strength is determined. That is facial muscle weakness, bulbar muscle weakness, limb muscle weakness, respiratory weakness, ocular muscle weakness. This all checked by the experts, and then it is diagnosed. It is always present. Ptosis means eyelid are so weak that they are very commonly or they are in almost blinking situation is there. Bilateral facial muscle weakness is there. Sclera below this nimbus portion of the eye that may be exposed due to weak lower eyelids. Eyelids are getting down more, so eyes are not properly closed. Then bulbar muscle, that is muscles of the bulbar portion, they will be weakening. Then the palate portion is there, so palatal muscle will be there. So person may have nasal voice. Nasal regurgitation means fluids will come into the nasal area. Chewing may become difficult. This is they are in the oral cavity. Okay. See, we are discussing same thing. Severe jaw weakness may cause jaw to hang open. Swallowing may be difficult. Aspiration may occur. Aspiration is again a problem. We have seen earlier with organophosphorus poisoning that whenever such thing happens, the aspiration, that means secretions are there and they are difficult to manage. It goes into respiratory tract, they can obstruct and can cause more damage. Then upper bulbar, that is neck muscles, neck flexion and extension are problem. Flexions are more affected than the extensor muscles. Then next is the limb muscles. Various muscles in the upper extremities and lower extremities are affected. Examples are deltoids, wrist extensor, finger extensor, tricep, biceps. Then hip flexors, quadriceps, hamstrings, foot, dorsiflexors, plantar flexors. These are all various muscles that are affected. Then next in that is lastly, if respiratories are there, I told you intercostal muscle and diaphragm are important. I told you already, and it may cause difficulty in pulmonary ventilation, that is inspiration and expiration of air. So it will cause hypoventilation, and neuromuscular emergency of the myasthenia gravis can be there because it is the most dangerous situation. The weakness of pharyngeal muscle may collapse the upper airway, and therefore immediately the mechanism has to be there. Pulse oximetry may not exactly reveal the situation, and therefore more diagnostic test and then immediate action has to be taken. So I'll not go for all this. Already we have seen ocular muscle weakness. It can be one side is more and one side is less. Weakness of the lateral and at the latter, now not immediately, because when we say that it started with the ocular Vaibhavi, then bulbar, then neck. Okay, slowly when it goes ahead, then definitely we will be facing problem in walking when it reaches to uh, the extremities. Okay, not only walking, even the hand movements also. So at every places it will be there, but if it is diagnosed early, and the treatments are done, then definitely it can be prevented. Because for initial stage, always it is ocular and facial and all type of such muscles are there. So that is important to understand. Yes, it is slow process, and then slowly one after another muscles are affected. It depends. This is the routine one, but there may be some patient in that sudden it has occurred. But usually, we already seen that this is the usual process. Then next in that is there can be some coexisting autoimmune diseases are there, like hyperthyroidism. It occurs in around 10 to 15% of the myasthenia gravis patient. So, because of that, the person will show exophthalmos, that is enlargement of eyes, uh, that is just like eyes are coming out of the socket, almost big eyes, and tachycardia will be there because of the hyperthyroidism. Weakness can also be there, and it will not improve with the treatment of NG alone because hyperthyroidism is also causing weakness. One more autoimmune disease like rheumatoid arthritis can also be there. Scleroderma can be there. Lupus erythematosus are there. These are different type of autoimmune disorders which you shall study in different section. Basically, you just remember because this can happen with myasthenia gravis. Why it is causing idiopathic? Idiopathic means it is not known. Okay. The cause idiopathic, when many times you do encounter this word idiopathic means where etiology is not understood, why it has happened. Okay. So this type of diseases we call them as idiopathic. Then in second cause can be penicillamine. Penicillamine is the complexing agent which is used in some of the toxicological things to chelate the ions which are there. So these acetylcholine receptor antibodies are found in 90% of the patients which are developing this myasthenia gravis, and that happens with the penicillamine exposure. So penicillamine that occurs as a triggering force, and this antibodies or penicillamine somewhere comes in contact with this receptor. For that, you have to understand the mechanism, what we call it as a hapten. Okay, you just note it down what haptens are if you have studied somewhere. So these haptens are there. These haptens, they are otherwise normal molecules in all the person, but in some persons this hapten will able to bind with some of the proteins in the body. So normally that hapten is not antigenic, that protein is not antigenic because it's body part. But when this hapten combined with the proteins, they alter the basic chemical. It is not complete change or covalent bonding, but whatsoever the ionic forces which can be seen, they are altered, and because of that, it feels as a antigenic, and these antigenic forces will cause antigen antibody reactions, and because of that the antibodies are produced. So wherever these are there, the antibodies will be attacking it, and because of that what we have seen, that action will be seen, and there are certain drugs which can show the actions. Which are these drugs? Some antibodies like aminoglycosides, example streptomycin, etc., ciprofloxacin, ampicillin, erythromycin, some beta blocker like agents like propranolol. Lithium is one of the drugs. Magnesium, procainamide, verapamil, quinine, chloroquine, and antimalarial drug, prednisone. Timolol is ophthalmic drug, anticholinergic agents. Some of these, not in all, in some percent these are linked. A very small proportion, but any of these can be linked in some patient. Doesn't mean that it is causing to everyone, but in some persons it has been happening. So I'll not go for this because there are many simultaneous diseases are there, and this is particularly not much important for us. Now, what we'll do is we can test the anti-acetylcholine receptor antibodies. If they are positive, that is, it is almost in 70%, 74% patient it becomes positive. That is a very clear diagnostic feature. It is 80% present in generalized myasthenia, 50% of patient with pure ocular myasthenia, only ocular, no other. So it is present in that. Then we have got other type of test, that is anti-striatal muscle antibodies. They are present in 84% of patients with pyoderma who are younger than 40 years age, and that is also another diagnostic feature we can have. Then interleukin 2 receptors, they are increased in the generalized and bulbar forms of myasthenia gravis. Interleukin, if you remember physiology last week, you might have studied. This is one of the cytokines which is present. It is increased in various reactions, particularly in immune reaction. Okay, and it plays very important role in thymus mediated or cellular immunity. So they are very important. When next year you shall see the immunosuppressants, you will find that these immunosuppressants, the drugs are acting on this interleukin 2. Either they decrease its formation or its binding with the receptor. Then various X-rays can be done, chest X-ray, etc. MRI of brain can help brain and the orbits. Other causes like cranial nerve is not affected, it is checked with the brain, so that because sometimes it can be because of cranial nerve also. But if cranial nerve is not affected, then it is 100% myasthenia gravis. Then electrodiagnostic, nerve stimulation is done repetitive. Single fiber electromyography, that is called as also done, and it is more sensitive than repetitive nerve stimulation. That gives the a part of treatment also. Then how it is done? This is non-pharmacological part. You just understand that these are the techniques. There is no need to go in more detail because it is not available in pharmacological books. It is just information that how done for myasthenia gravis. Now let us go for pharmacological. So very first thing is edrophonium. But we have seen earlier, edrophonium is edrophonium is a acetylcholine esterase inhibitor, and it is having very short duration of action. And for that, very important tensilon is its brand name. So it is called as edrophonium test or tensilon test. There are variety of patients which can have similar sign. Myasthenia gravis has got low number of acetylcholine receptor, but there are some patients which are having more acetylcholine. As I told you, there are two. That is called as a cholinergic crisis. There is one more disease, acetylcholine more acetylcholine. That is cholinergic crisis, or Huntington's chorea, in which also acetylcholine is more. So it is acetylcholine is there. We know about how what happens. We have seen acetylcholine release. Acetylcholine esterase is metabolizing it. Edrophonium is acetylcholine esterase inhibitor. It is short acting, and therefore it will increase the acetylcholine level for short duration. Then when hydrophonium is given, then check the weakness before an administration of the hydrophonium. Now let us see what happens. Before that, you can see that ptosis is there, that is the eyelid is half. Okay. Now after that, it is covered, it is recovered. That shows sign that yes, hydrophonium shows that now the person is having myasthenia gravis. Simple test. Then next is steps. Zero point 0.1 ml of 10 milligram per ml hydrophonium is administered as a test. If no unwanted effects or side effects are noted, like sinus bradycardia, then that means particularly we know that it has got a it can cause the hypersensitivity reaction. So if it is no hypersensitivity, then we can go for the remaining drug we can administer. It can improve the weakness in disease other than myasthenia gravis, like poliomyelitis and some peripheral neuropathies, but it is less. Okay. So once it is diagnosed, what are the treatment? That is acetylcholine esterase inhibitors is the most important treatment. We know about them, physostigmine, pyridostigmine, etc. We can classify them. Then other treatment is the immunomodulating therapies, because it is an autoimmune disorder. This is not part of our treatment. You do not concentrate much on other treatments because immunomodulating you have got in syllabus in the next year, but you just remember that it can be done. Plasmapheresis is a separation. Okay, removal of the unwanted things or particularly antibodies is separated. We know that these are the antibodies. So from plasma, these antibodies are separated. This is called as a plasmapheresis. Thymectomy or removal of spleen particularly. Thymus removal is important treatment. Thymoma is present. If thymus is there, so various SEA inhibitors is important. You just remember about SEA inhibitors. We have seen various acetylcholine esterase inhibitor of that pyridostigmine. It is onset of action is 30 to 60 minutes. The duration of action is 3 to 6 hours. The dose has to be individualized because person can have variations around 60 to 960 milligram per day, depending on the person and the condition. Orally, it can be given. If it has to be given intravenously or intramuscularly, you can understand how much dose we have reduced. Just 2 milligram dose, intravenous or intravenous, intramuscular. Why this? We know because if it is orally, then it can be less absorption. It can be first pass effect. Many drug it can be protein bounding, and because of all these aspects, we have to give higher doses. Okay, but if it is intravenous, then directly going to the uh, circulation, first pass can be avoided. Same is the intramuscular, and therefore dose is too less. This is what basis you have understood earlier. Okay. Then check for cholinergic crisis. Cholinergic crisis means too much acetylcholine whenever it is there. It is there. The other are the neostigmine is another drug. Then immunomodulators, I told you, I'll not go and discuss. These are the glucocorticoid and other drugs which are used. They are immunosuppressant in nature and they will decrease the antibody formation. Okay. Then other behavioral modifications are there. The patient may experience difficulty in chewing and swallowing due to oropharyngeal weakness, and if this is called as a dysphagia, difficulty in swallowing. Liquid should be thickened, and they can be thick liquid should be there so that aspiration means the fluid entering into respiratory tract is called as aspiration. So we have to avoid this aspiration. A patient should be advised to be as active as possible, should rest frequently to avoid sustained activity. The patient should be educated for fluctuating nature of the weakness and exercise induced fatigability. So this training has to be given. We have seen that it can cause respiratory failure if it progresses. Dysphagia, that is difficulty in swallowing. Then complications which are secondary to drug treatment can be particularly long-term steroid use. Steroid use means we have seen prednisolone just now as an immunosuppressant. So it can cause osteoporosis, it can cause cataract, it can cause hyperglycemia, it can cause hypertension, it can cause gastritis, peptic ulcers, etc. And most important is it can increase the immunity. Therefore, the person will be more susceptible for any kind of infection, particularly hemocystis carini is one of the infection which can be there because these patients are more susceptible for infections. Uh, Prognosis is very important term which you will encounter in therapeutics. Very important. You just remember prognosis means what will be the outcome of the treatment when you are now started the treatment. So what will happen to the disease? Okay. So if the patient is not treated, the mortality rate is 25 to 31%. This is the prognosis. That means if the person is not treated, what is the outcome? What will be the progression of the disease? Disease will cause death of the person. What is the prognosis after the treatment? If the treated as per the guidelines, then it has only 4% of the mortality rate. That means one can reduce mortality rate from almost 25% to 30% to 4%. Then what is next? 40% have only ocular symptoms. Okay, that means out of 100% of myasthenia gravis, the 40% patient will not go beyond ocular. they will have only ocular. That means they don't have chance of having dysphagia, they don't have chance of having respiratory problem, and only 60% of those with ocular, they will remain exclusively ocular at the end of 2 years. So initially it is ocular, but fortunately those who can diagnose it in the first 2 years only, then we can stop their progression into the next type of muscles. But this 60%, if they are not treated, then they will go for bulbar and other kind of muscle weaknesses, and it may progress into respiratory. So mind well, respiratory is the most dangerous. Uh, in other cases, once it is there, the treatment is started, then we can protect the people. Okay. Now, what are the strategies for that? We can do the rehabilitations of the patients. We can educate the patient. We should the person should be informed that yes, they have got this kind of situation, and what should just now we have seen what other thing we can do about. We can show about diet. We can show the activities. We can guide about the fluctuating nature of fitness and exercise and this ability. Then the exercise expert guidance like physiotherapist can be taken and according this can be produced. Then timing of the activities, again as we have seen earlier, at what time some exercise has to be done, then some rest has to be done. So proper chart has to be made. Then adaptive equipments can be given, which will be helping the person to do the activities in better way. Providing the assistive devices, whatsoever devices which can assist them, uh, they can be provided, and some of the exercises can introduce, we can tell about them. So here we have finished about myasthenia gravis. Basically, what myasthenia gravis is, I hope you understood, and go for basically important treatment is what the acetylcholine esterase inhibitors. Okay, so we have used this acetylcholine esterase inhibitors. They will increase the concentration of acetylcholine in the synapse. Okay. Now, my question is: suppose when we are giving acetylcholine esterase inhibitors, what they are supposed to cause? What are their action? Increase acetylcholine. Where it will cause increase in the acetylcholine? At synapse. Which at which